Okay, shall we begin?
Hi, Shireen. Hi, Rekha.
Hi.
Hi, Shireen.
Yeah, we can start.
Can you guys see me?
Yes, Mila. Hi. Yes, we can see you.
Amela.
Hi. Morning, everyone. Oh,
Good morning.
afternoon.
Afternoon.
Hey, good night.
It was difficult navigating time, so I haven't greeted anybody by time of day.
Can we
Okay,
all mute
ladies.
if we're not supposed to be speaking?
Hello and a warm welcome to our host, our members and our guests. I'll begin with a brief introduction to Without Filters. It's a space where we support and encourage the search for meaning through the listening without bias or prejudice. It's a gendered space in that it's women only. And today we have a significant other amidst us. Welcome. Getting through housekeeping, do ensure your microphone is on mute, that you switch off your video if stepping away from the meeting, and that your mobile device is set on silent. Questions. Do post them direct to Delaney on chat, else use the yellow hand raised emoji to alert the moderator you wish to ask a question. Please note that we may not have time to get all the answers, but we will do our best. Rekha will be on hand to address any technical issues. Posters, all these housekeeping info is posted as housekeeping info on chat. The presentation today will be preceded by a Q&A session. We have the chairman of the Newport Medical Group and the medical director of the Oxford Medical Center, who is hosting us today. A consultant clinical gerontologist. He is a member of the Caribbean College of Family Physicians, the American Association of Geriatric Psychiatry, and the Gerontological Society of America. Dementia, according to the WHO, is currently the 7th leading cause of death among all diseases and one of the major causes of disability and dependency among older people worldwide. Dementia has physical, psychological, social, and economic impacts, not only for people living with dementia, but also for their carers, families, and society at large. It is the lack of awareness and understanding of dementia which results in the stigmatization and barriers to diagnosis and care. Our host is super equipped to help us gain a greater awareness of dementia. He has addressed many sessions locally and internationally on aging-related issues and has several published papers on adult sexuality, successful aging, and dementia. The Q&A session will be chaired by Dr. Delaney De Silva Chen. The panel consists of Drs. Albert and Delaney Chen, Dr. Dushanti Pereira, and Dr. Mrs. Lorraine Yu. Dr. Delaney is a consultant occupational health physician in private practice. Having read for her master's in public health, she provides services to several corporate entities. Dr. Dushanti Pereira, head of anesthesia and critical care at Durden's Hospital, Colombo, has an interest in end-of-life care. And an MD in anesthesiology, Dr. Pereira is a fellow of the Royal College of Anesthesiologists. She holds a diploma in medical education and was senior lecturer in anesthesia at the University of California. Mrs. Lorraine Yu co-founded and incorporated the Lanka Alzheimer's Foundation. The World 2020 World Alzheimer Report, titled Dementia-Related Design and the Built Environment, cited the design of the foundation building reflecting its vision extremely well. The link to this report is also posted on the chat. Mrs. Lorraine retired in September 2019. She is willing to answer questions related to the foundation. Dear members and guests, please join me in welcoming Dr. Albert Chen, President of the Alliance on Aging Jamaica and the Chairman of the Alzheimer's Disease Outreach Program. It is the fondness and the deep attachment Dr. Chen had to his grandparents, who lived in the family home post-retirement, which shaped his passion in caring for the elderly. Over to you, Dr. Chen, and thank you.
Okay, good morning, everyone. Can you hear me?
Yes.
Yes.
Yeah.
Yes.
Okay, let me see if I can. Can you allow me to share my screen? Okay, can you see my screen?
Yeah.
Okay, thank you. Okay, thanks once again for your kind invitation to participate in this wonderful ladies only forum. I hesitated to show my video earlier because I felt lonely being the only male face on screen. So if you allow me, maybe I will remove my face so that the beautiful faces of the ladies can predominate. All right, so yes, we're going to talk today about dementia and how to prevent it. What is dementia? It's a general term we use to describe the mental decline in elderly persons as they get older. Memory impairment seems to be one of the first things that we notice, and Alzheimer's disease is the main cause that we know about. In truth, dementia can be caused by many other illnesses, Alzheimer's being only one of them. Parkinson's disease, strokes, and other conditions may lead to dementia. So the term that we use, dementia, is really an umbrella term which describes all the other causes. So when you make a diagnosis of dementia, it's not a complete diagnosis actually. So you want to say the person has dementia due to Alzheimer's disease or due to a stroke, which we call vascular dementia, or due to something else. This is important for physicians because the treatment of the different causes of dementia varies. And so Alzheimer's disease accounts worldwide for the bulk of the causes of dementia. But in our neck of the woods in Jamaica, it's actually vascular dementia. In other words, very small strokes in the brain, which is a major cause of dementia. In other countries, the major causes may also vary. Why are we talking about this? It's a problem. It's a major problem worldwide. The cost for caring for dementia exceeds the combined cost for caring for heart disease, diabetes, and cancer. Currently, over $1 trillion is spent worldwide for dementia care annually, and the cost is increasing daily. The projections are that the number of persons worldwide with dementia will only increase in the next 30 to 40 years. Today, we have about 54 million persons worldwide with dementia, and the projection is that by 2050, almost 115 million persons will be diagnosed with dementia. And this is across the board in various areas of the world. In 2011, Alzheimer's Disease International did a survey which looked at the prevalence of dementia in persons over 60 in various areas of the world. As you can see in this slide, in Australasia, almost 7% of those over 60 have dementia. In Southeast Asia, just over 6%. In Western Europe, just over 7%. But in Latin America and the Caribbean, over 8%, a whopping 8% of those over 60 have dementia. Where I am in Jamaica, our studies are showing about 8.2% of those over 60 being demented. And I'm in the Caribbean and in Latin America. If we look on the map, we see that these big numbers of greater than 8% of those over 60 occurs in these areas from Mexico, Guatemala, El Salvador, Panama, Costa Rica, and then the Caribbean islands, and then you have South Florida, and in the center of it, there's this little dot called Jamaica. And this is where I'm coming from. So you can understand that the topic of dementia is one that is very important for us in this area. Unfortunately, this problem seems to be common in other areas of the world. It's my understanding that about 4% of those in Sri Lanka are also demented in those over 60 years of age, and maybe about a similar number in Bahrain and other areas in the Middle East. So it is a major problem worldwide, and it is an increasing problem. When we sit in this area of the world and discuss with our colleagues, we project that by 2050, the numbers will increase by a whopping 535%. So dementia is a problem today, and guess what? It is likely to be a problem tomorrow and going forward. And therefore, it is important for us to discuss this topic. And I suspect it is this realization why Shireen and Rika and the others have organized this seminar on dementia, and not as a respite from the discussion on COVID-19. So what are we talking about? Alzheimer's disease is the major cause of dementia. It appears that as we get older, there's the accumulation of some insoluble particles in the brain. We call these particles beta amyloid plaques. They are deposited in the brain between the neurons, interrupting the communication between neurons. And then there's also the deposition within the cells of the brain themselves of a protein called tau. This disrupts the flow of nutrients within the cells. So cells die because of insoluble particles being deposited between them, and because of insoluble particles being dissolved inside the cells themselves. And so this is a cartoon which shows the deposits between the cells, and then we see a normal brain where everything looks clean and clear. But let us try and give a scientific definition of dementia. Dementia speaks to multiple cognitive deficits. It's not correct to say someone is demented if all they have is a memory problem. At the same time, it is not correct to say someone is demented if they have no memory problem. So memory dysfunction is a cardinal sign of dementia, especially in learning new information or short-term memory. Apart from memory, however, there are other problems which are usually present. There are problems with language. Persons with dementia tend to have difficulty using and understanding language. For instance, Alzheimer's disease is associated with significant impairment in understanding and using language. So if someone is suspected of being demented and they're able to complete an understandable sentence and say, today is Saturday, the 18th of September, and I am joining a group of beautiful ladies to discuss dementia. You can say, thank you very much, you do not have Alzheimer's disease. Because persons with Alzheimer's disease cannot construct a sentence in that way. It doesn't mean they don't have dementia, but it is not due to Alzheimer's disease. So language is a problem. Apraxia is another problem. In other words, they are unable to carry out purposeful movements. So you ask them to put on a blouse, and they have a difficulty. And we may think that they have forgotten how to put on a blouse. It's just a problem of converting the idea into motion, inability to carry out purposeful movement. And then there's agnosia. Agnosia is the inability to identify and recognize objects, even though you know them. And so we show someone with Alzheimer's disease an orange, and you say, what is this, Mom? And they will take it and they will look at it and they will squeeze it and they will smell it and say, I don't know. And then we tend to believe that they have forgotten what's an orange. No, that's not a memory problem. That's an agnostic problem. So that's another problem that you will identify. And then there's a problem with executive function. In other words, the higher functions of the brain, the ability to in society. Dementia. On top of that, these deficits should be severe enough
Is Dr. Chen frozen? Yeah. No.
I'm going to check on it.
Yeah, sure. Sarah, try hotspotting from your phone through the phone.
Yeah, I've done that. I'm hotspotting, but it's still, it's the JIT aspect.
Okay, okay.
So, but I've completely frozen.
Now you seem to be okay. Because we can hear you and
Yeah, no, it's fine now. No, it's fine now, but he is.
Yeah, but it
frozen.
just keeps going, right? Yeah.
Yeah.
Fluctuation and the
But the doctor has frozen completely. So.
yeah, I think he's connecting back. So
He's connecting back.
yeah, sure.
Is Dushi on? I haven't seen her yet.
No, she's not. I'll message her.
Okay, I'm sorry for that technical difficulty. Are we back?
Yep. Yes.
Okay.
Yes,
So, as I was saying, all these deficits that we're talking about should represent a decline from previous level of functioning. So the person should have been functioning properly all along, and then we find that their level of functioning has deteriorated. So the person who says to you that, listen, I've had problems with my memory all my life, all through school. All the girls know that I couldn't remember anything in school. That person is not demented. As I keep reminding my friends, that person is more likely mentally retarded, but that person is not in this group. So what we find is that persons with Alzheimer's disease tend to forget the last thing that they learned. So they have difficulty remembering what they had for breakfast, but they can tell you about some event that occurred many years previously. If we were to look at the top 10 warning signs of dementia, they would look like this. Problems, recent memory problems affecting us while we're still at work. Difficulty performing familiar tasks, language problems, disorientation in space and time, poor judgment, problems with abstract thinking, misplacing and forgetting things, changes in mood, changes in personality, and a loss of initiative. So when we see these things in our older relatives and friends, we need to get very suspicious that something may be happening and reach out to them. So I want to thank you once again for your kind invitation. The last 10 minutes I've been trying to give a broad overview of the topic and allow the audience to get a feel of my Jamaican accent. Having done that, I hope we can now move on to the substantive topic, which is preventing dementia. We are going to try to share some ideas because there are other members of the panel who are very experienced in this area. We're not prescribing any treatment or anything. We're simply sharing ideas, describing approaches which may be used. I know that in other areas of the globe, other approaches are being looked at, and it would be great if we could share that information this morning. So we're going to talk about dementia, not as a destination. People don't just go to bed doing very well and wake up in the morning being demented. We're going to look at dementia as a process. We're going to look at the risk factors of dementia as legitimate targets of prevention. We're going to try and understand the processes involved and see how we can devise a treatment at this forum going forward. So, people age, and some persons find that their mental function slows down as they get older. Some people find that they have significant deterioration in their mental functions. And others around them also identify that they are not functioning as well as they used to. Over time, maybe years, some of these persons will develop dementia. And so we move from normal aging through a condition called mild cognitive impairment, which may last for years, to a point of dementia. Interestingly, every year, maybe 40% of persons with mild cognitive impairment will revert to normal aging. So this does not normally go in one direction only. We have also found recently that in the community, some persons with mild cognitive impairment will remain with mild cognitive impairment for decades and never convert to dementia. And I mention this because if we're going to talk about prevention, we want to attack not just persons who are normal today, but also these persons with mild cognitive impairment represent a unique group for us to engage in intensive prevention strategies. Another way to look at it is that as you get older, there is a slowing in the conduction of nerve impulses, and that occurs to everyone. But some persons find that their mental function deteriorates significantly more than would be expected. And what we find in these persons is that over time, they may begin to show signs that are picked up by others, and later they may become demented. So it's a continuum. Okay, so, okay, right. Now, what does this depend on? Does it depend on your genetic makeup? Yes, it does, but it depends on other things. It depends on insults that we may be exposed to throughout our life. Episodes of stress, depression, exposure to chemicals, lead, mercury, divorces, insecticides, head traumas. So these factors may predispose you to moving from the line at the top to the dotted line and towards dementia. So to the extent that you can prevent these insults to your brain, you're actually preventing dementia. On the other hand, there are also protective things. A good diet, exercise, lot of good fat in your diet, lot of good plant food in your diet, good relationships, participation in seminars such as these, will help to maintain your brain and prevent dementia. So all of this we can do without actually taking medications or anything. Let's move to another slide. What we have found, especially in persons with Alzheimer's disease, when we do a MRI of the brain and we look at the accumulation of the beta amyloid and the tau in the brain, we find that a lot of persons with cognitive impairment, you can see a lot of red and orange areas which represent an accumulation of these deposits we spoke of. And so we understand that these persons have Alzheimer's disease because we're seeing it on their MRI. And then some persons who are cognitively normal, when we look at their brains, we see that the brains are relatively clear. And so we say this person has a very limited chance of developing Alzheimer's disease. But there's a subset in the middle of persons who are cognitively normal. But when we do their MRI scans, we are seeing a significant amount of these plaques and tangles. They're cognitively normal, no signs of dementia. And yet we are seeing these accumulation in their brain. This group is the ideal group for us to initiate prevention. Many of you would have been concerned that over the last 2 to 3 decades, we have not made any serious headway in the prevention or even the treatment of dementia. And we suspect that that is because we have been intervening in persons who are already showing signs of dementia. In other words, they already have significant destruction in their brain. So there's not enough good substrate left for us to act on. And so we have been working now on patients long before they develop dementia. The A4 study is looking at the anti-amyloid treatment in asymptomatic Alzheimer's disease study is looking at treating persons before they develop symptoms. And then there's another study that's looking at persons years and years before, simply on the basis that they may have a family history. That's the anti-amyloid prevention study. So this is an approach that we're taking. Now, when we look at persons with dementia and we try to intervene to prevent it from getting worse, it's called tertiary prevention. When we look at persons who may have signs in their brain of plaques and so on, but no symptoms, this is referred to as secondary prevention. But when we take young persons in their 30s and 40s, before these substrates are being deposited in the brain, that is called primary prevention. And I went through this slide because I want us to understand that dementia is a process, and if we want to prevent dementia, the best time to intervene is before the pathological process begins in the brain. And we know that this process may take 20 or 30 years. So we want to intervene today. So the strategies that we're going to look at are strategies that we want to start today, not later on. Okay, so let's look now at the risk factors. Risk factors are things which increase the chance of you getting a condition. It doesn't mean you're going to get the condition. Some people will get the condition without the risk factor. But they represent something which we can look at and try to modify. When we talk about dementia, and certainly Alzheimer's disease, these are the 8 top major risk factors. In red, we have age, family history, gender, and what we call apolipoprotein E status. In other words, whether or not you have a certain type of lipid carrier in your blood. And these are referred to as unmodifiable risk factors. In other words, we're not able to do anything about it. And then there are modifiable risk factors such as high blood pressure, high cholesterol, diabetes, which are considered to be modifiable risk factors. When we look at these 7 modifiable risk factors, diabetes, hypertension, obesity, smoking, depression, physical inactivity, and so on, we find that they account for just about a third of the risk of dementia. So the risk of dementia that you can modify to reduce your risk accounts for just 30% of the risk. So 70% of the risk of dementia is due to factors that are unmodifiable. So we as gerontologists have decided that this is not a condition that we can accept. So we have decided to look seriously at the non-modifiable factors to see what underpins these factors and what can we do to convert them from being non-modifiable to being modifiable. And that's what we're going to do now. So let's talk about age. Now, most of us try to modify our age by finding a more experienced hairdresser or a very good cosmetologist. And we certainly need to have our plastic surgeon on speed dial, you know, so we deal with all those issues. But the age still accumulates. We find that the number of persons with dementia doubles every 5 years beyond age 65. And it doesn't matter how beautiful you look. Between 60 and 65, maybe 1% of those persons will have dementia. But as you get older, the number increases. So there's absolutely no question about it, that age is the major risk factor for dementia and Alzheimer's disease. So please don't pay attention to this slide. Just pay attention to my soothing voice. What we have found after prolonged research is that free radical proliferation in the brain might be the major cause why age is this great risk factor. And it might very well be that there's an accumulation of free radical proliferation as you get older. Why? Because the free radicals might be accumulating more, and the ability of the brain to neutralize these free radicals is reducing. And it's obvious then that the approach should be to try and reduce the accumulation of free radicals on the one hand, and on the other hand, to try and improve the brain's ability to neutralize these free radicals. Most of the external signs of aging, the aging spots, the macular degeneration, the depigmentation in certain areas, the wrinkles, all these are signs of oxidative stress or free radical proliferation. And so there is enough evidence that if we can control free radical proliferation as we get older, we can slow down the aging process. Now, what are free radicals? Free radicals are chemical species that contain an unpaired electron in their outer orbit. It makes them very unstable. So they react with other substances in your body and interrupt the function of these substances. Free radicals like to attack the cell membrane. When they do that, the cell membrane becomes more permeable. So substances which should not enter the cells start to enter, and substances that should remain in the cells and not get out are getting out. So what increases the risk of these free radical formation? Let me say that free radicals are formed normally. We are not fighting against free radical formation. We are against the uncontrolled proliferation of free radicals. And this occurs when you're exposed, for instance, to excess sunlight, air pollution, ionizing radiation, smoking, excessive exercise, alcohol, those who are diabetic, inflammation. All these are factors which increases your free radical production. Frying, deep frying is a major source of formation of free radicals, which combine with the fat in the food that we fry. And when we enjoy those fried meals, the fat is converted into fat into your nerve cells and so on. And the permeability of the cells are impaired. So free radicals have an unpaired electron, and to neutralize them, we need to give them an extra electron to make them stable. And anything that offers an electron to a free radical is called an antioxidant. And that is how you neutralize free radicals. You need a diet that is rich with antioxidants. And this diet is something that we're going to discuss shortly. In young persons, we find that there are always free radicals, but there are enough antioxidants available to neutralize them. And so they tend to remain much more healthy. These are some of the free radicals. You don't have to try and remember them. And on the right in red, these are the names of some of the antioxidants that are produced in the body to neutralize those free radicals. In the young brain, there seems to be a good amount of antioxidant to neutralize the free radicals. But as you get older, the free radicals tend to outweigh the antioxidants, and we tend to have more inflammation, especially in the nerve cells. And herein lies the root of premature aging. These free radicals, we find, they stimulate the formation of neuron factor kappa B cell activator, which leads to certain things: macular degeneration, so your vision deteriorates, osteoporosis, Alzheimer's disease, atherosclerosis, Parkinson's disease, rheumatoid arthritis, and any inflammatory illness that you can think of. So free radicals are a major cause of many of the illnesses of aging. Here I try to share with you that the brain has its own antioxidant system to neutralize free radicals. And at the forefront of this cycle of antioxidant is vitamin E. Vitamin E reacts to neutralize free radicals. It is the first substance which will act on these free radicals to neutralize them. So obviously, the first solution is to have a diet that is rich in vitamin E. When vitamin reacts with free radicals, it is deactivated. And for it to be reactivated, you need vitamin C. So here is the second area to remember. You need a diet that is rich in vitamin E. You need a diet that is rich in vitamin C. When vitamin C reacts with the deactivated vitamin E, the vitamin E becomes active, but the vitamin C becomes deactive. The deactivated vitamin C can be reactivated by an enzyme called glutathione peroxide. The production of glutathione requires vitamin B2 and other B vitamins. So we are coming to a solution where if you want to maintain your brain antioxidant cycle, you want to have adequate vitamin E in your diet, adequate vitamin C in your diet, and adequate B vitamins in your diet. I will tell you that this is the most important slide you're going to look at. Vitamins E, vitamin C, and the B vitamins, and we're going to get back to it. So, amyloid seems to be a major risk factor in the development of dementia. There's a protein called amyloid precursor protein, which exists in the brain. A section of it is in the nerve cells and a section in the cytoplasm. And then there are enzymes which splices these beta amyloid to form small pieces. Depending on the size of the pieces, they may accumulate or they may dissolve. And what determines the size of the pieces that are formed when beta amyloid precursor protein is spliced? It depends on the enzyme which does the splicing. The enzymes could be like the scissors. Depending on the scissors, the pair of scissors that you use, you get particles of different sizes. And if we can control the type of scissors that we use to splice the amyloid precursor protein, then we can control how many beta amyloid is formed. Of course, we also want to look at factors which will reduce the amount of amyloid precursor protein which is in the brain, and we're going to discuss that. The other thing I want you to remember is that here on your left is a chromosome. The red section represents a small part of the chromosome, which is a gene, and the gene may encode for a particular protein. So let us say you have a gene for blue eye. Now, the gene has different sections. It has 2 exons, which may code for a protein, but it also has a section which is called the promoter section, which may turn on or turn off the gene. What it means is that having the gene for blue eye is not enough for you to have blue eyes. If those genes are turned off, you're not going to have blue eyes. Are there factors that we know that can control the turning on or off of genes? So we're going to discuss that in a minute. So if that is so, we may be able to influence the genes that predispose you to dementia. So just bear that in mind, that having a gene doesn't necessarily mean that you're going to get a condition, because there is a possibility that you can inactivate the gene. And what we have also found is that certain conditions, such as exposure to harmful chemicals, may activate certain harmful genes. So by avoiding exposure to pesticides and organophosphates and so on, you may in fact be allowing the good genes to be turned on and the bad genes to be turned off. This is the concept of epigenetics, where you can control your gene impression by your own action. The other thing I want to focus on briefly is the fact that we all know this is the DNA double helix, which constitute a lot of different nucleotides. Well, the nucleotides come under attack or mutation on a daily basis, and the brain has the ability to repair any damage. There's a very unique site. It's the site we call the cytosine guanine site, which comes under attack regularly, where a methyl group is removed. And the site is converted from a cytosine guanine site to a thiamine adenine site. You don't have to remember those words, but this allows the structure, the physical structure of the DNA to change and predisposes person to the accumulation of harmful proteins. So if we can control the conversion, in other words, if we can allow the brain and the DNA to repair this cytosine guanine area by adding methyl groups, then we can prevent the conversion which tends to occur as we get older. And what have we found? That to add methyl groups to the DNA to repair them, what you need is a diet that is rich in folic acid, vitamin B2, B6, B12, magnesium, vitamin D. So a lot of what occurs as we get older, which predisposes us to dementia as we get older, can be corrected, because we now understand that there is a demethylation process taking place in the DNA, which is why the older DNA is more prone to the formation of beta amyloids. And we can deactivate this process by a diet which is rich in folic acid, in other words, green leafy vegetables, vitamin B2, B6, B12, and magnesium. And so we have looked at age and how it is possible that we can reverse age from being the major risk factor in the formation of dementia. Next so-called non-modified risk factor is family history. leaving your family and migrating doesn't mean that you change your family history. Okay? Both early onset dementia and late onset dementia are serious genetic predisposition. Let us look at persons who have early onset dementia. Most of them are suffering from what we call autosomal dominant Alzheimer's disease. It means that once you have one of the gene, the dominant gene, then you're going to get Alzheimer's disease at an age maybe of 40 or 50 or early 60s. So let us look at these two young persons in their 20s. Beautiful lady and a beautiful young man. They met. The young man has one of the genes for Alzheimer's disease. The lady has none. They have 4 children. Well, 50% of the offspring will have the gene for this type of Alzheimer's disease. And in other words, each child has a 50% chance of developing dementia by age 50 or 60. Another good reason why you want to follow the family history of persons when you start to date. Now look at this one. 2 young persons, beautiful people, both have one of the genes for Alzheimer's disease of the autosomal dominant type. None of them know the family history. 70% of their offspring will develop this type of dementia. In other words, each child has a 75% chance of developing Alzheimer's disease. So I just wanted to show you that, yes, genes are important. And why is it important? Because these genetic predispositions determine the amount of amyloid precursor protein that they have in the brain. And the more amyloid precursor protein you have, is the more when they are spliced, you're going to get the beta amyloid, which will accumulate. So let us talk a little about when the amyloid precursor protein is spliced. Normally, amyloid precursor protein is spliced by 2 scissors or enzymes. One is called alpha secretase and one is called gamma secretase. When alpha and gamma secretase splices the amyloid precursor protein, you get some small particles that are soluble. So they are washed out of, so you get a type of amyloid which is washed out of the brain and they are not toxic, they create no problem. However, in some persons, we have 2 different scissors splicing the amyloid precursor protein. We have the gamma secretase, but instead of the alpha secretase, we have the beta secretase. When you have the gamma and the beta secretase splicing the amyloid precursor protein, you get small particles of amino acid, which leads to the formation of beta amyloid, which is insoluble or insoluble. So if we were to be able to find a way to deactivate the beta scissors and activate the alpha scissors, then we might be able to prevent the formation of beta amyloid. So is there a way that we can turn off the genes that lead to the formation of the beta secretase? Because the beta secretase is the problem. And we are going to look at and see what we can do to achieve that. And we have already discussed how that might be achieved by controlling the conversion of the cytosine guanine nucleotide bond to the thiamine adenine. And we remember that we decided that we will have a diet that is rich in folic acid, vitamin B, B6, B12, vitamin D, and magnesium. In doing that and adhering to this type of diet, we are actually deactivating beta secretase. So you deactivate the beta secretase. So alpha secretase is more active. So the soluble form of amyloid is formed and the insoluble form is not formed, so that we reduce our risk regardless of our genetic makeup. So we still have the same genes, but we are now allowing the formation of the amyloid, which can be washed out of the brain. What about gender? Now, gender is an extremely dangerous topic. And we, being of a different generation, used to believe that there's just male and female gender. And I'm going to stick to that definition and not discuss the more modern gender positions. So we have found that being female increases your risk of developing Alzheimer's disease. Being male increases your risk of other types of dementia. But for Alzheimer's disease, being female seems to double your risk. Why is that? We have discussed a lot of things. I have suggested that it might be the excessive shopping that the ladies do, but we're really not sure, right? Right now, we believe that one of the risk factors for dementia, which is the apolipoprotein E, which we mentioned, seems to occur more frequently in women. So women are at increased risk, not because they spend more time in the kitchen, which is what we used to think, because they don't do that anymore, with certain exceptions. It's not because of the makeup, it's not because of the chocolate, what they're eating. It appears that they do have a greater amount of the apolipoprotein E in women than in men. Now, this apolipoprotein, as we saw, is one of the 4 non-modifiable risk factors for dementia. Now, apolipoprotein is actually a protein which helps in the transport and metabolism of fat. It can occur in different ways. You have a 3 allele, a 2 allele, and a 4 allele. And you need to have 2 alleles. When you have 2 of the 4 alleles, E2, E4, the risk of dementia increases 15 times. When you have 2 of the E2 alleles, the risk of dementia is 50% less. In other words, when you have 2 E4, you have a significantly greater risk of dementia. When you have any combination with E4, then you have an increased risk. And women seem to have more of the E4 than men, which seems to explain why women are at greater risk. Later on, I'm going to describe a way in which women can neutralize this risk. Now, apolipoprotein E4 is a major problem. It reduces the function of the synapses. It causes atrophy of the brain. It stimulates the accumulation of beta amyloids and plaque. It interferes with the metabolism of cholesterol and lipid. It reduces the metabolism of glucose and energy formation, and increases the chances that your cells will not be able to create energy from glucose. So apolipoprotein E4 is a major risk factor. It seems to be more common in women, and that is something that we need to be aware of. And so cholesterol has long been shown to be a risk factor for dementia. The higher your total cholesterol, the greater your risk of dementia. In this regard, the high-density cholesterol seems to be protective, while the low-density cholesterol seems to be the major risk factor. And there are various studies that have shown that high cholesterol at midlife significantly increases the risk of dementia in late life. But this study showed an interesting thing, which we will come back to, that persons who were on simvastatin, which is a cholesterol-using drug, had a reduced risk of dementia. And I want to come back to this because there is accumulating evidence that the risk factor of apolipoprotein E, which is major in women, can be neutralized if their total cholesterol is reduced. In other words, women have an increased risk of dementia primarily due to apolipoprotein E4. But if you reduce your total cholesterol to the level of about 3.5 under 4 millimoles per liter, then you remove apolipoprotein E4 as a risk factor. This is a major point. It means that even if you have this genetic marker, you can remove it as a risk factor by taking steps to keep your cholesterol under 4. So women need to pay attention to this. High blood pressure has also been shown to increase your risk. I'm going to go through this very quickly. So as diabetes increases the risk of Alzheimer's disease by 65%. And we're going to spend a little time on that. For every 1% increase in your HbA1c, which is a marker of the control of your diabetes, the risk of cognitive impairment increases by 50%. So being diabetic is bad enough, but when your diabetes is not properly controlled, it makes your chances of dementia even greater. The brain cells use a lot of glucose, and diabetics tend to have a problem with the use of glucose in the brain because of a condition that we call hyperinsulinemia. Now, hyperinsulinemia interferes with the entrance of insulin and glucose into the cells to form energy. And hyperinsulinemia is a major part of prediabetes, diabetes, high blood pressure, cardiovascular disease, but also obesity and sedentary lifestyle. Hyperinsulinemia is turning out to be a major risk factor for even vascular dementia. In Jamaica, the major cause of dementia is a thing we call small vessel disease of the brain. And these persons tend to be hyperinsulinemic. And this graph just gives you an idea of how high insulin levels or the poor metabolism of insulin and glucose can cause serious cardiovascular problems and dementia. Finally, I'm going to talk about this protein, this amino acid, which is called homocysteine. Homocysteine is an amino acid which is formed when you heat meat. Dietary protein is broken down to give you an essential amino acid called cysteine, and homocysteine is an intermediary stage. Now, we have noticed over the years that persons with cancer, stroke, heart attack, and dementia have a high level of homocysteine in their blood. And we have never been able to understand why. Now, looking on this slide, you can understand that persons with a high homocysteine are not going to have enough cysteine because your homocysteine is high because it's not being converted to cysteine. So essentially, homocysteine is telling you that the person has a deficit of cysteine. So what is cysteine? Cysteine is an important requirement for the formation of glutathione. And what is glutathione? Remember we mentioned in the antioxidant cycle of the brain that you need glutathione to convert vitamin C to its active form. So again, we find why the deficit of cysteine or the accumulation of homocysteine is important, because it reduces the availability of this antioxidant. And here is a slide, and here we can see that glutathione is important for the conversion of deactivated vitamin C back to active vitamins. And let's look at the cycle to see Here we have the cycle which shows the conversion from methylene to cysteine, and we see in red that this conversion is facilitated by vitamin B2, folic acid, vitamin B6, and vitamin B12. Where have we heard that before? Somewhere before we have heard that vitamin B2, B6, B12, and folic acid is important for methylation in the brain. And now we're finding out that the same vitamins are important for the formation of cysteine, which is an important antioxidant form needed for the production of glutathione. So when we talk about the need for the B vitamins to protect your brain and to prevent dementia, it cannot be overemphasized. Because however we look at prevention, we're coming back to the same factor. A diet which has enough vitamin B2, B6, B12, and folic acid. So, okay, so let us now look at the processes that we have discussed. We have noticed that oxidative stress is an important part of our risk. So we're going to have to find a way to neutralize it. Excessive inflammation goes with oxidative stress, and we're going to have to find a way to neutralize inflammation. Impaired DNA methylation is a major reason why age is a risk factor for dementia. We're going to have to find a way to help methylation as we get older. Hyperinsulinemia seems to be a risk factor, and we're going to have to find a way to deal with hyperinsulinemia. We have looked at the point that vitamin B2, B6, B12, and folic acid are very important for methylation, but for the production of cysteine in the brain. So we're going to look at how we can increase those vitamins in our diet. We have looked at apolipoprotein E as a risk factor in women, and we have looked at how bringing your cholesterol down to between 3.5 and 4 millimoles per liter can reduce that risk. And we have looked at homocystinemia as really a sign that a person has a reduced level of cysteine in their blood, and we can neutralize this problem. And we are going to look at how, once again, we can neutralize this problem. So we are slowly building a pyramid of how to prevent dementia. We have looked at the antioxidant cycle, and we have seen that we need a lot of vitamin E. We need a lot of vitamin C to keep the vitamin E active. We need a lot of cysteine so that we can have glutathione peroxidase. But to have enough cysteine, we need the B vitamins. So we need the B vitamins, we need vitamin C, and we need vitamin E as a start. So we need a diet to neutralize the free radicals. And here we have the major free radicals scavengers, in other words, antioxidant, vitamin C, provitamin A, vitamin E, bioflavonoids, and we have the solution on the right. We need fruits and vegetables for vitamin C. For beta carotene, we need anything that has the color of mangoes or carrots. Anything that has that orange color, pumpkins. Vitamin E, it cannot be overemphasized. Vitamin E is the first contact with your free radicals in the brain. Lots of fish, nuts, and grains. We have flavonoids and carotenoids, which are plant food. You can't have enough plant food. The more colors there are, the better. Lycopenes from tomato, alpha-lipoic acid from broccoli, and so on. So this is the approach that we're recommending. Melon seems to have a lot of the antioxidant superoxide dismutase. So watermelon is an approach that we can use. To deal with inflammation, turmeric. Where have I heard of this? Is this correct? Turmeric has strong antioxidant and anti-inflammatory properties. If you want to fight dementia, you're going to have to start using curry. Curry has a cousin called ginger. Ginger has the same properties of scavenging free radicals and fighting inflammation. You want to eat ginger, you want to drink ginger, you want to dream ginger. Ginger also fights COVID-19. All my patients are telling me that they use ginger to fight COVID-19. And I am following my patients in that regard. So ginger is a very, very good anti-inflammatory and free radical scavenger. Lemongrass, fever grass. Lemongrass has strong antioxidant and anti-inflammatory properties. It protects your brain. It grows all over the world. So let us add this to our diet. Sorrel is a drink made from an hibiscus plant. It is very common in the Caribbean and in other parts of the world. Very strong anti-inflammatory and antioxidant properties. Moringa. We all know moringa. Well, moringa, you can drink it, you can eat it, and whatever else you do. Strong antioxidant, anti-inflammatory properties. But guess what? It also has a lot of vitamin B2 and B6. It has vitamin C, it has magnesium, all the things that we need as antioxidant. The strongest antioxidant we know is really omega-3 fatty acid. Now, omega-3 fatty acid and omega-6 fatty acid are the primary fatty acids in our diet. If you have a ratio of omega-6 to omega-3 of 1:1, then you're doing fairly well. If you have up to 5 times more omega-6 than omega-1, then you're doing reasonably well. But the average Western diet has up to 30 times more omega-6 fatty acid. Now, omega-6 is pro-inflammatory. In other words, omega-6 will promote inflammation, which we're trying to prevent. Omega-3, on the other hand, prevents inflammation. So let us look at how we can increase the amount of omega-3 in our diet. So the omega-3 fatty acid you're going to get from olive oil and fish oil, on processed food, nuts and grains, cold water oily fish, walnuts, flaxseed, and pumpkin seeds, olive oil, canola oil, grapeseed oil. Did I mention fish? These are some of the great sources of omega-3 fatty acid, and it doesn't have to be expensive. Mackerel, herring, sardine, tuna. If you're worried about mercury, then you can focus on more sardines and herring and salmon. So omega-3 fatty acid is a revolution. It reduces inflammation. It reduces your cholesterol level. It reduces the adhesiveness of platelets. It increases your good cholesterol. It reduces depression. It reduces insulin resistance. And it increases the level in your brain of 2 important fatty acids, DHA and EPA. Many of you are mothers and you know that all the formulas will have in bold writing contains EPA and DHA because it's very important fatty acids for brain development. That is what omega-3 does for you. And that is how we're going to prevent dementia. Homocysteine, we mentioned, if you want to reduce your homocysteine, in other words, if you want to increase your cysteine level, you want a diet that is rich in vitamin B2, B6, B12, and folic acid. What are we talking about? Nuts and grains, fish, green leafy vegetables. Another tool that we have been looking at is what we call the modified ketogenic diet. Increasingly, we're finding that fat is not necessarily as bad as we're being told. You see, when you have a diet of fat, the fat is broken down to form ketones. The ketones will enter the brain and they will be used to form energy. So especially in persons with diabetes who have hyperinsulinemia, therefore there is no energy being formed in the areas of the brain that are important for memory. These persons would benefit from more fat in their diet. In fact, these persons would benefit from coconut oil. Coconut oil is metabolized to give you ketones, which can be used to form energy in the brain. Metformin. Metformin is a drug that has been used for diabetes for years. Metformin is an excellent drug to reduce hyperinsulinemia. All the doctors in the Western world are now taking metformin because it reduces inflammation, it increases cellular survival, it increases stress defense in the cells, it increases the destruction of dead tissue, it improves protein synthesis, and it prolongs life. Metformin is a significant part of any arsenal in the prevention of dementia, especially if you have diabetes or if you're overweight. Again, we have discussed
What is this?
use of certain drugs called statin, and we have made the point that reducing your cholesterol, if you're a lady, below 4 is important if you want to deactivate apolipoprotein E. But what we have also found is that the use of a statin also deactivates the enzyme called beta secretase. So the use of a statin deactivates beta secretase, which is important for the formation of beta amyloid. So even if we have a family history of Alzheimer's disease, we can deactivate beta secretase by taking a relatively low dose of a statin drug. And we have looked at this slide and we have explained. So in conclusion, we want to adhere to what we call the modified Mediterranean ketogenic diet. We're going to have a minimum of 5 to 7 servings of fruits and vegetables every day. Lots of plant food, lots of fish, lean poultry and eggs, nuts and grains. This is the diet that I'm recommending for you. So in summary, to prevent dementia, we need to understand that dementia is not a destination, but it's a process. And therefore, we need to begin the prevention process today. We have looked at the risk factors for dementia, and we have looked at age and family history, and we have looked at gender, and we have seen that we can go beyond them to prevent dementia. We have discussed the pathogenic process of hyperinsulinemia. We have looked at the proliferation of free radicals. We have looked at low methylation. We have looked at high cholesterol, and we have decided that we have found a way to neutralize all these factors. I therefore want to invite you to approach your dementia prevention task by, first of all, adhering to a diet that is rich in vitamin E, vitamin C, and the B vitamins. You want to have enough magnesium in your diet. You want to have, maybe take a metformin supplement. You want to possibly look at reducing your cholesterol to under 4. You want to keep your blood pressure under control, and you want to keep your blood sugar under control, and you want to exercise regularly. I want to thank you very much for your time, those who are still awake, and I think we're going to have a panel discussion where we can discuss further any questions. Thank you. So back to the moderator.
Hello. Since there's a little bit of silence on, I have a quick question, Albert. You were talking about the active vitamins.
I'm sorry, is this Dr. De Silva?
Yes, your sister-in-law.
Hi, how
Talking
are you?
about active vitamins. So are the basic vitamins I'm taking not active? Is there a different kind of vitamin that's active? I didn't quite understand.
No, well, it is you, if you're taking a very good multivitamin, then you should continue. However, I think you need a B complex, which has greater concentration of the B vitamins, because we are not just taking the vitamin to maintain our health. We're trying to prevent dementia, especially in persons with a family history.
Yeah.
So if we have a family history, if we're female gender, then we have to do a little more than average. So I'm recommending that we have a little extra vitamin C, a little, well, maybe much more vitamin B1, B2, B6, and B12. That is what I'm recommending, because the B vitamins are so important. Not to forget vitamin E, which you get from your fish, which comes back to show why the fish is so important, not just as a source of vitamin E, but as a source of omega-3 fatty acids.
And if you're not taking fish, I gave up eating fish. So should I be taking a vitamin E supplement?
Absolutely, Dr. Silva. Absolutely.
Oh,
And
dear.
then remember, you also get it from your nuts and grains. So you want to
But I
have
eat
your,
a lot of greens. Yeah. Okay. Thanks.
okay.
So if we are including all the fruits and the fish and everything in our diet, is it still required to take the vitamin supplements?
I am not sure that we need to worry a whole lot about overdose of vitamins, with the exception of the water-soluble vitamins. When you have a diet that is very rich in fish and nuts and grains, you should be getting adequate amount of vitamin E. But as I mentioned, most of your multivitamins give you enough vitamins just to maintain basic standard health. But we want to go beyond basic standard health to a point where we're trying to prevent dementia, especially in those of us with a family history of dementia. So taking a Centrum Silver, for instance, may be good if you have no family history. But even in those persons, I recommend that you take at least 500 milligrams of vitamin C additionally, and you take some vitamin B complex additionally.
Thank you.
Because we're not only preventing dementia, but we're trying to stay young and beautiful.
With all the
Albert.
antioxidants, that's what we were thinking, that everything they sell it as rich in antioxidants. So we just try to gobble it up.
Right, I didn't hear the question that well.
I don't think there was a question.
Yeah,
was
I
a
was just
statement.
commenting that how we tend to focus towards antioxidants because everything is now sold to us as rich in antioxidants, and then we just go for it.
Yeah, I think we have to be very careful about the food and so on, the processed stuff that we buy, which says that they're rich in antioxidants. I think it's important enough for us to decide that, listen, I'm going to eat my fruits that I know I'll get the stuff from. It doesn't matter if this product says it has a lot of antioxidants. I'm going to have my fruits and my vegetables, and I'm going to have my fish. Because my health is my concern. And it's very important if you have a family history of dementia. And as I mentioned, being a lady is its own risk factor for dementia. So being a lady, I'm not going to take any chances.
Shall we open the panel discussion now?
I had one question. If you don't eat enough fish, is it okay to take fish oil or flaxseed oil?
Yes, absolutely. Absolutely, yes.
Excuse me, I sent a few questions into Delaney. Is Delaney
Yes,
going to ask them, or how is it going to do?
Sarah, so I was trying to invite the panel on. We have Dr. Dushanti Pereira and Lorraine Yu on as well. There were a couple of questions posted to the chat from Sarah. But she's asking the effects of depression and stress on dementia. So would you like to take that first, and maybe some comments from the other panelists?
I'm sorry, you want, okay.
One was effects of stress and depression on the development of dementia.
Okay, I may just say very quickly before the other panelists jump in, that depression seems to be a major risk factor for dementia. We have found that persons who have had episodes of depression all their lives, so they have recurring episodes of depression, they do not necessarily have an increased risk of dementia. But persons who develop depression in late life, so persons who develop depression at 50 or 60, they have an increased risk of dementia, because it appears that in these cases, the depression is an harbinger of dementia. So yes, the depression is a major risk factor, especially in persons who are developing the depression at late life. Now, stress is also a major risk factor because it increases the entire inflammatory cascade in the brain and in their body. So yes, it reduces your ability to neutralize your free radicals, so it puts you at increased risk. But I'll be keen to listen to what the other panelists have to say.
Dushi would like to take up any perspectives on depression and stress on dementia and aging?
Sorry, I'm having a bit of trouble with it. I just rushed from a hospital back home. Now, actually, I do want to, from like I told Shireen, I'm not an expert on this, but I actually from observation, because and a few comments actually about prevention and actually in handling these patients. I'll give a little bit of background. I hope you don't mind. My mother is 86 now. She was about 81. She was working until she was 81, quite active as a physician. And she had a sudden loss of speech. It was quite sudden. It just slowly, so her speech slowly deteriorated. It was mostly initially a difficulty in finding the correct word, and then slowly it gradually diminished her ability to speak. And she was diagnosed as, we did the MRIs, there was nothing really found in that. So she was originally diagnosed as dementia, but I kept insisting that it wasn't, because knowing her, I knew that she knew exactly where everything was, the house where her keys were. She still managed her house and everything like that, it went on. Then subsequently, I think after about 3 or 4 years, 3 years or so, with repeated MRIs, finally it was agreed it was not dementia, but that she had actually had some small strokes because she's a diabetic. And it was considered that she had a small stroke in the Broca's area, and that was what led to this. We had also stopped her from working by then because she had a very good reputation, and we didn't want her to, because of her difficulty with language, to have people, commenting on her lack of ability to communicate. She was such a good communicator before. Well, she was managing a house, and my parents very active. They were going for their concerts and plays and book clubs. And though she couldn't speak, she was always involved in lots of things. And then came COVID. And with COVID came the lockdown, because we locked down pretty quickly in March, April last year. Now, until then, she had been managing her household completely by herself. And COVID came, and then everything stopped. And it was just two of us who were doctors who were able to come in and out of their house. Other than that, my other sisters couldn't come. And there was a very sharp deterioration in her cognitive function and her physical ability. Both came together. So I believe that the depression, because she was such a social being, that depression really caused a huge decrease in her cognitive ability. So I think there is a big, that all these have a lot to play, actually. And soon after, despite having lockdowns now, we still keep our family lunch on Sundays. All of us still go just to keep her engaged, you know. And we also have a family Zoom meeting every Sunday with all her siblings from around the world. We meet every afternoon, and from 3:30 till about 6, it may be still going on, 6:37, where everyone sort of listens, and she's also on it. So I think I do believe that depression can actually hasten very drastically the onset of dementia. She probably had element with small microvascular, and subsequent MRIs have shown, one that I did last year before, showed small microvascular damage to the basal ganglia. Sorry.
Thank you, Doshi. Lorraine, would you like to comment?
Sorry,
Lorraine,
did you? Yes.
would you like to comment on the effects?
No,
of stress?
I believe. Sorry? I
Would you
can't
like-
hear you.
I'm sorry, would you like to comment on the question, the effects of stress and depression on dementia, and your experience with your
Yeah, depression increases your risk of getting dementia. For example, at the Lanka Alzheimer's Foundation, we have an activity center for people who are diagnosed with dementia. And we find that has been very beneficial for them, in the sense that it retards the progression of the dementia, because they're engaged in social interaction, mental stimulation, physical activities. So like Bushi said, unfortunately with COVID, even the activity center, because the activity center they feel very safe, secure, because it's a non-judgmental environment. So people who have dementia, because they're socially isolated, they feel comfortable coming to the activity center at the Lanka Alzheimer's Foundation. And we find that since COVID, and they haven't been able to come to the activity center, a lot of them, the progression has been very rapid, as Dushi said, you know, because they don't have that opportunity to go out and socialize and interact with people and engage in activities. So I agree with Dushi on that, that it can progress rapidly if you, the depression, and
So
not being able to.
Reversing the depression can actually prevent dementia. Am I correct, Albert? If it's caught early enough, because there are various.
I don't like to use. I don't like to use the word prevent. You can delay the onset. You can retard the progression, but you have to do things to delay the onset, I think, but treating depression, yeah, you need to, that's a different area altogether. But as Dr. Chen said, episodes of depression throughout one's lifetime can increase your risk of getting dementia in your later years.
Yes. Thank you, Lauren. So we have another question from Chen. Actually, she has two. The first one is, how would end-of-life palliative care be mapped for a dementia patient? Should be encouraged, a living will be encouraged? I think that's what she meant. A living will be encouraged.
But we, in Sri Lanka, we haven't come to that advanced stage of living will and all that. Unlike in the developed countries, we find that because what happens is the diagnosis is made usually at a later stage. Very few people get an early diagnosis so that they can plan there, so that's why awareness and is very important, because then that enables people to get an early diagnosis. And a lot of people anyway are in denial. So denial, not accepting there's something wrong, tends to delay the diagnosis, So living will is something that is not really happening in Sri Lanka for people with dementia because of the late diagnosis.
Thank you. Dushi, you would like to comment?
Yes, actually, that's something that I also have been really asking for, is this living will. I think we should, it's not only for dementia patients, but others as well. And we really need to, lobby with the legal fraternity and try and get this as part of our, into our legal framework. Because because I work in intensive care, I deal with end of life care. I've been really trying to lobby for do not resuscitate for the patients where it is futile. Because I work in the private sector now, and I find, it is sometimes, with futility, continuing care and then keeping on giving CPR to patients who may not, where it is an end of life situation is, and we do not have any legal framework for that at the moment. But we are in discussion with that, and hopefully with that, they may hopefully tag this living will concept as well. Because I have spoken about living will as well. I think it's very important in this day and age where we live much longer, and where our medical abilities are much greater in terms of just maintaining organ function rather than actually having a quality of life. That's what's important, a quality of life rather than just life,
Albert, you have any comments?
Yes, I think the situation in Jamaica is quite similar to the situation in Sri Lanka. However, we, being closer to the US, are beginning to take a lot of their bad practices of families being separated. And this becomes extremely important when you have people getting older, but the children are maybe abroad, and it's difficult to find someone immediately around the patients to make a decision. Then you need some documentation. But generally, the idea of living will is very important. And I think it's something, as Dushi said, that we need to promote and encourage. And it will solve a lot of problems for the older folks and for the younger ones too. But if I may just add one word, Delaney, about the stress and depression. Stress and depression is mediated through the formation of cortisol. Cortisol is this hormone which is released when you're depressed, when you're grieving, and when you're stressed. And cortisol increases your blood sugar. It also increases dyslipidemia and insulin resistance, and they are risk factors for dementia. So yes, in fact, depression and chronic stress are risk factors for dementia. The other thing is that by treating your depression, you actually reduce your cortisol production. So it is true, as Lorraine said, by dealing with the depression, you're actually reducing your risk.
Thank you. We have a question from Shanez. Go ahead, Shanez.
Hi. So I like to make a comment really because I'm a clinician in whole food nutrition. And I believe in the gut-brain connection. And when it comes to depression, what I always find is that people are low in B vitamins, which now Dr. Chen has said that affects the dementia as well, and also the gut bacteria, because there are plenty studies to show that gut bacteria and what is there and what is not there does affect lipid profile, the depression, the way you think, your weight, and various things like that. So I think that's an important factor to take into account. The other thing is we did see in the presentation that dementia and Alzheimer's disease and all that is on an upward trend. And we are all eating foods, especially in Sri Lanka. We have the turmeric, we have the ginger, we have the coconut, we have all those lovely vegetables. We do eat all that here, but still dementia is on the rise. And I believe that it is also because there's glyphosate. The environmental factors. Glyphosate is shown, there are plenty studies to show that glyphosate does open up the blood-brain barrier. It opens up membrane.
That's
so,
right?
Sorry?
The pesticide?
Pesticide, yeah. So glyphosate is in pesticides, and that there are plenty studies to show that that is opening up the blood-brain barrier. So toxins are going into the brain, which you never found long time ago, but now it's on the increase with more and more glyphosate usage. So all that also affects this increase in dementia and Alzheimer's. I believe that. And also there are studies to show that commercially grown vegetables and fruits have far less nutrients than organically grown produce. So you might think you're eating lots of vegetables and fruits and getting all the nutrients, but if you are not getting the amount you need from the vegetables because of how it's grown, you are losing on that. So I just wanted to comment on that.
Shanez. There's a question from Shireen. She has read on the current uses of integrated medical approach to trauma. She would like to know how far Jamaica has used this method in regards to mitigation of dementia. Albert? The integrated medical approach to trauma.
I am not acquainted with that approach. Obviously, it's not something that is being done in Jamaica, and I would love to hear a little more about it.
Shireen, would you like to take that? Would you like to speak on it?
Sorry, I didn't hear the question.
No, Shireen's question, Shireen.
I wanted to say that one of the I want to talk about one of the reasons the numbers are going up is because we have an aging population. So as we know, age is the biggest risk factor. As you get older, the percentage of people with dementia increases, right? So because we have an aging population, that's attributes to the numbers of people living with dementia is on the increase. So environment, yes, but also because of the aging population in Sri Lanka and all around the world.
Thank you, Lauren. Shireen?
Yeah, it's the compassionate inquiry into one's well-being, the ability to understand that it's the importance of emotions, the impact of one's one's person outlook to life, all those aspects has its impact on one's well-being and has an impact on one's health. So that's that's what I meant by what did I say? I can't remember my question.
Integrated.
That's what I meant by integrated, because there are certain physicians in Canada and in the US that I have read on. One, Dr. Gabo Mate in Canada. There's Basil van der Kolk. There are some physicians who do adapt this concept of this approach of the compassionate inquiry into clinical practice. So where the body is viewed as a total, there is no separation of the mind from the body and the body from the mind. So the human being is taken with whatever their problems be, because in one of Dr. Gabo Mate's presentations that I listened to, he says, the approach should be to ask you when you go in with probably presenting a condition of maybe a headache or whatever the physiological complaint be, it's not what's wrong with you. The question should be what happened to you.
I agree. If I can make a comment on that, I believe that, illness has several root causes: nutritional deficiencies, structural issues, toxins, and also unresolved emotional conflicts. And if you don't take care of those unresolved emotional conflicts, those can come to haunt you later, and that does affect your physical body. I think, mental, emotional things do trickle down to the physical. So I think that is an important aspect which you need to address in these things.
Thank you, Shanice. There's a question from Sarah to Albert. Do you see a lot of fear among your patients of getting dementia? Or is it that something just that creeps upon people? Albert, about getting it?
Yeah, well, yes, particularly in persons with family members with dementia, there is a concern. And yes, possibly a fear. In most other persons, they simply don't want to think about it. They just forget, I don't want to hear about this. In fact, it's very interesting that the two least exciting topics today are COVID and dementia. And to get us some relief from the discussion on COVID, Shireen has decided to let us talk about dementia, which is an improvement. But people are afraid of dementia and they rather just not know about it.
Can I make a comment about this? My uncle had Alzheimer's. He was the world's leading authority on tuberculosis. He got Alzheimer's. So he went from being Professor Emeritus to an unbelievable, it was very sad to watch, but it was also a very interesting experience for me. And as an observer from the outside, I used to go and visit him every week until I moved to Bahrain. His wife would go, but none of the members of the family would go. And they couldn't face the changes. But I learned so much from him. He was 60, I think, when he went with Alzheimer's. And initially, that was why I was asking about depression. He was diagnosed with depression, and they said it's either early onset, it's either Alzheimer's or it's depression, and it turned out to be Alzheimer's. And he kept it secret from the family because he knew something was going wrong, but he couldn't quite. So he'd gone from this, very erudite gentleman to beginning to realize that something was going wrong. And the longest time he stayed at home, but then he went into a nursing home, a very good nursing home. And I discovered this fabulous relationship that I had with him while he was mostly pretty much unable to communicate. And he would babble and he would, but his personality, his true personality was there. All his inhibitions went, and he told you exactly what he thought of people in the family. It's hilarious. Particularly my father and other members. And he didn't quite remember my husband's name because he'd only met him later in life. So he would go, that man, that man, the man with the beard, the man, right? So anyway, but gradually, it's a long story, gradually his cognitive ability declined considerably. He used to pinch things from the other ladies in the place and whatever. But every now and then, he was totally lucid. So he would babble, and we would be having a conversation about, he liked art, but it was completely, a one-sided conversation. But then all of a sudden, a completely clear sentence would come out that was totally accurate and the right thing to say at that time. And it was usually very humorous and whatever. And it made me realize that people with dementia and people with Alzheimer's and all the different things, still the same person in there, and every second they know what is going on. And he would babble, perfect sentence that was absolutely correct for the conversation. And then, so I'm just telling you this story to encourage people not to fear it. It was a completely different relationship I had with him. I really enjoyed going to see him, and I was so sad that the family, the children would not go because they couldn't cope with the changes. And so that was my question, why I asked about fear. Because yes, my husband went once or twice, but then he said, no, I can't cope with this. I can't cope seeing him like this. And he was very uncomfortable, whereas I was quite like, so I think there's a lot to be done about the social side of this and getting communities to accept that people who have dementia and Alzheimer's are not a different person. They're still that person there. And every so often, he knows what is going on. He knew his situation. So please don't treat people with dementia like they're children, because they're not. He was still the professor. And the nursing home dressed him in a suit, called him professor. He was treated as he was before he lost his abilities. But that was just my little bit.
Can I comment on that, Lini?
Go ahead, Dashi.
Yeah. So actually, I can add to that. I quite agree with you, Sarah, because I've noticed that with my mother too. A lot of people outside the family, I mean the extended family, were often, and her friends who used to visit, were often discouraged by the fact that when they would talk to her, she would start to cry or make an attempt. And for a time, even we were worried. But then it suddenly clicked with me that because she couldn't speak, it's like a baby. The only way they can communicate is by trying to verbalize, is by crying. And so now I tell everyone, don't worry if she sort of looks like she's crying. It's not that. She's trying to tell you something, but she has no other way of communicating with you. And we realized that was one. The other thing is, like you said, Sarah, that person is still in there. So we have a carer for her, and now we have two. What I did was I took them, because she used to dress beautifully, and I used to get so upset when I go and see her. And she's in her old night dress with food on it, and she would never have been like that. She would be pristinely dressed with matching earrings, matching shoes. She dressed beautifully. My colleagues used to scold me and say, I don't dress like my mother, because she was always beautifully dressed. So I took some more photograph albums out, And I showed them all those photographs of her in her different, aspects. And then it definitely changed the way the carers cared for her, because then they looked through her whole wardrobe, got all her stuff organized properly, though we had done it, but when they wash and put away, we had not always taken them. And I said, and anyway, we were throwing away all these things that looked old and making new clothes for her. So put all that, and now they always dress her nicely and make sure that she looks like she used to. And I think it has changed her as well. She feels better. She always sits with us for our Sunday lunch, and we make her eat as much as possible with her spoon and fork, so that she feels that she's we don't try, we are, and our conversation goes on around her. So of course I think a one-to-one conversation would do better than a lot of noise around it. Anyway, I just want to share that because I agree totally with you, Sarah. The person is there and you should treat her like that.
Thank you, Lucy. This concept of shut-in where people even...
One comment.
Sorry?
I'd like to comment on what Sarah said. There was someone who had Parkinson's.
You're breaking up. Not hearing you. Can you repeat the question, please? Okay, until
it's frozen. I think it's frozen.
Yeah, it's frozen. So until she comes back, the concept of being shut in, I think that was a concept generated when someone develops cognitive impairment. The family, the immediate family sort of, starts to hide the person, not taking them out to the family gatherings, not allowing visitors to come to the house. I think we have moved away from that, right? And even for the person to go to their church service or to go to a family get together, it is important because the person just sitting there may not be communicating verbally, but they get a happiness about when seeing persons around them and enjoying the familiarity, which they knew. They might feel strange in the new environment if it is different from their regular environment. They might not recognize the caregiver so much, but when they are with old friends or the church community, the temple, community, the family gatherings, I think they can recall some of the past because, like Albert first said, they lose the more recent memory first, and they retain the older memories much longer. So Ishana is back. I think we have some more questions.
Yes. Can you hear me now?
Yes, Shanice, go ahead.
Okay. So a comment I wanted to make was there was a hypnotherapist who said that every time he hypnotized someone who was having Parkinson's, the shaking would stop. And to ask Dr. Chen whether he knows anything about it, because if you're constantly shaking and you have very severe Parkinson's symptoms, how does that stop when you're under hypnosis? So that was just an interesting thing, that is there, something we still don't understand about all these neurological issues. That's just a comment I wanted to make.
Albert, you want to take that?
Interesting idea. I'm not sure. I understand and I believe it is possible that under hypnosis, the shaking might stop. I'm not absolutely sure how this occurs and how we could use it in our clinical practice. The shaking and the tremor in Parkinson's is an intentional tremor.
Yeah.
Right? So I don't know how that influences the process. It's something seriously that we ought to look at. Not that we want all our persons with Parkinson's to be hypnotized, walking around in hypnosis, but it is possible that after a session of hypnosis, the shaking and the tremor may actually recede for a period of time, maybe for a week or so. Then we could develop sessions, right? So they come in once a week or once a month, and over time, we may have improvement. It's a very interesting concept. It's something that we need to look at. I cannot at this point explain it though.
Rushi, can you give a perspective through your space in anesthesiology?
About dementia.
No, about the tremor.
Tremor. No, I was thinking of this intentional tremor anyway, the intention tremor. And that probably in hypnosis, what happens is you've disconnected. The intention tremor is if the patient wants to say, pick up a mug of coffee, then the tremor starts. But if they're at rest, there is no tremor. And therefore, probably hypnosis is more like being at rest. The mind is sort of disconnected from its intentions. But one other thing I would like to ask is I tried virgin coconut oil. I think it does have a benefit. I mean, there are lots of people who have said that as well. And I have added it to my mother's that. And one time she was deteriorating and I actually thought the coconut oil was still being given. And then my father said, no, we haven't given it now for a few months. We restarted it and I'm sure there was definitely an improvement. So I quite believe in this virgin coconut oil that we give 2 tablespoons every morning after breakfast. And again, I mean, it can even be put on top of a salad and things like that. So we do use that. And I feel there is some
Sorry, running out of time. So one last question from Hina. Hina, you want to take the floor?
Yeah, hi everybody. So just wanted to thank everybody for their valuable input. It was quite interesting. I came in because I was interested because my father, who's almost 80 years old, is kind of have been just diagnosed of an onset of dementia. And I was keen to learn more about it and understand how it is. It's just that it's been more than 10 years or so where there were a few symptoms and which were being linked to depression. And then again, as everybody was discussing the effects of COVID and everything, and I think there was a link there. So, and then we were seeing some new, developments there. So my question was to Dr. Chen. What I noticed is that some of the terms are being used interchangeably with dementia, like Alzheimer's and Parkinson's, and so I was a bit concerned, and I wanted to understand. I know that in the beginning it was said that it's an umbrella term for the different memory-related diseases, but what kind of if I would want to know if the doctor has said that it could be an onset of dementia, what was diagnosed to him, what would be the likely chances of him developing, like, let's say, something more specific like Alzheimer's or Parkinson's or something on those lines. I don't know if my question is clear, but yeah.
Okay. Right. So in the initial stages of the presentation, I made the point that the term dementia is an umbrella term which speaks to a decline in your mental function, but doesn't necessarily tell you what is causing it. When we use the term Alzheimer's disease, then we are speaking of a specific cause. So dementia can be caused by Alzheimer's disease. Dementia can be caused by stroke. Dementia can be caused by Parkinson's disease. Okay, so I'm saying that your father may be developing dementia doesn't tell you what type of dementia. And you really need to find out what type of dementia is he developing so that you can begin to intervene, because the treatment for the different types would be different. And some types of dementia, you can actually significantly slow down the rate of progression. For instance, if the dementia is caused by a stroke, or what we call vascular dementia, we know how to reduce the risk. You want to control your blood pressure, you want to make sure your cholesterol is down, you want to take a blood thinner. So we know what to do in those cases. So these patients may have cognitive impairment, but because you know that it is caused by a stroke, even a small stroke, you intervene and they get no further strokes. So their mental condition does not deteriorate, which is sometimes a very good outcome, you know, that they are not deteriorating. If the dementia is caused by Alzheimer's disease, then it is progressive. There's no stopping it. You may, and this is arguable, but you may slow down the rate of decline, but it's going to go in one direction. With vascular dementia, you may intervene so that your father may remain at this level for 10, 15, 20 years, which is significantly better than him deteriorating in 5 to 10 years, isn't it? So it is important for us to determine the cause of the dementia. So when you're told that your family member is developing dementia, you need to take a step and ask what type of dementia, what is causing the dementia, because only then will you be able to know what to do.
Right. Thank you.
You said that was the,
Sarah,
sorry. Yeah, that was the last question, was it?
yes, but I'm giving you the floor to close.
No, I know I have to close. I know, that's right. That's what I was asking, whether it was the last question. Sorry. Delightful discussion. I've really enjoyed this. I have learned a lot, and I'm writing down all the vitamins that I'm supposed to be eating and all this kind of stuff. I'm thinking, oh my God, how am I going to get all those on my diet? You know, because I have a very restricted diet anyway. So, and I love the comment about gut health, because yeah, dodgy gut as well. So I think we all relate to that, and I'm hoping it's not going to affect our brains. I would like to extend a great thank you to Dr. Chen for his time this evening. It's been very interesting. And the other members of the panel have been lovely. One thing that just did occur to me, just as we were wrapping up then, was the use of language. And I think the language around dementia is very negative. And I said in my experience with my uncle it was positive. And I just did a quick Google. I know we're not supposed to do that while we're Zooming, but I did. And there is something called Dementia Words Matter. I will share it with the group. And it's an article for journalists about how to talk about dementia when you write, how to talk about dementia with other people, because I always keep thinking of it, somebody's demented was a very, very negative connotation when I was a child. You know, it was derogatory. And so I think we need to be very careful about the language that we use, because it's not necessarily the end of the world. It's a different world for the people in the family. And it doesn't help that society uses very negative connotations that they either lost the marbles or they're a bit crazy, or, you know, this kind of thing, because it's just the same person, really. So I would like to all do a virtual clap to the members of the panel. Thank you to everybody.
Thank you, Albert. Thank you so much.
I think it was the biggest turnout we've ever had. It tells you it's an important discussion. We should do it again sometime, because the other thing that was interesting in the paper today, Bahrain has a war on obesity. Big headlines. And it's and you said that Bahrain was around about 4% with the dementia. I think it's going to go up soon. Yeah, obesity is a big issue here, and other lifestyle issues, and the diet is not good. You know, it's a bit dodgy. So I think, yeah, it was a very timely discussion. Thank you very much.
Thank you.
Thank you.
Thank you very much.
Thank you, and have a good evening, all of you. Bye.
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 Thank you.
Bye.
Thank you.
Bye.
Bye.